let's open it up to the panel now. And if I can ask the panel members to open their video, we can have a bit of exchange here and get started. So maybe starting with Harpreet, and then we can bounce around a little bit for about 20 minutes here and try to get a bunch of inputs. Harpreet, I mean, just in terms of your own experience in the region, in the area where you are in Brampton, what are some of the kind of mechanisms that are likely to be feasible in the community where you have one of the communities that has the biggest burden of disease as a consequence of diabetes? How to make sense of this? What kind of structure to try to create?
Yeah, excellent point, Terry, and thank you for that. So I practice in Brampton and Peel. It is part of the Peel region, so Brampton, Mississauga, and it can be called the capital of diabetes, if you will, in Ontario, because it has the highest prevalence of diabetes in Ontario, around 14 to 15%, rather than the national average of 10 to 11%. So part of the reason that this is the case, there's many different reasons, and we have to delve into what those reasons is. It could be a separate talk, but part of the reason is food insecurity. Part of the reason is the ethnic background, the work background, the working class, the senior population, and many challenges related to all of that, as well as the living environment that we have as well. Now, how do you tackle that? So this has to come from many different sources, and I'll give the example of COVID, right? So for COVID, we have face masks, hand sanitizing. We have the option of treatments for COVID, but all of them have to come together to try and overcome the challenge of COVID. Similarly, I think in diabetes, especially in ethnic terms, you have to kind of attack this problem from many different angles, which includes not just the hospital, but also community care, community practitioners, diabetes education resources that may be there as well. And not just that, but moving beyond to maybe religious places of worship, to maybe going into grocery stores, educating through that. So we have to think out of the box to I think, tackle that epidemic. And that's, in a sense, what Stop Diabetes Foundation, which is a small charity organization, it's based in Brampton. It's volunteers, healthcare providers who are trying to spread awareness. That's what we're trying to do.
Thanks very much, Harpreet. I think, the Toronto Star produced a map of diabetes in Ontario a couple of years ago. Very good map showing where the hotspots are and where the rates are extremely low. So just following up on this dialogue with you, to turn to David and just say, David, how do we actually engage primary care in a kind of structured way? Because obviously the scale of engagement with primary care is going to be higher in the hotspot areas. And while we have a good framework for primary care in Ontario, we also have a very fragmented kind of organizational structure for primary care. To quote Naylor, it's public payment, private practice in a number of places. So how do we actually deploy effectively primary care for these hotspot areas within Ontario?
And I'll quote somebody back you. I'll quote Eleanor Kaplan, who's not related to me because she spells her last name wrong with a C and not with a K. But I once heard Eleanor say, we're the only health system in the world where we throw money at the health system and hope to expect to get the results that we hope to expect. And partly in that private practice part is one of the difficulties. I think we did have a very good model a number of years back with our diabetes, our regional diabetes centers. They each had not just a primary care lead and a specialist lead, but they had a dedicated data person. Some of these people were very, very skilled at, even within a region like a LHIN, the old LHINs, finding the areas where we needed to make a difference. If it was in some of these, it was long-term care where patients were being placed on sliding scale insulin, and doing targeted interventions, primary care interventions in those homes, or doing pop-up testing to Harpreet's point, in malls where we knew there was a high incidence where people were underdiagnosed. We lost that because the strategy got folded into the LHINs, and many of the LHINs just took the budget, unfortunately, and didn't continue to have a diabetes infrastructure. I think now that everything's been collapsed into Ontario Health, that we have the great history of Cancer Care Ontario, and a model of care, I think we have an opportunity to rebuild that, because I don't think without the right meso level of support, and I think that's what's missing, the meso level support into the communities, that even Ontario health teams are not going to know where they need to focus, in which part of their communities, which patients. Without that data, it's very, very difficult to do the targeted planning. It doesn't, I have a practice that's partly split in North York and in Scarborough, because I practice almost right on the 404 in North Toronto. And I can tell you that my patients who live behind Bayview Village are at a different risk than my patients who live elsewhere. And unless you can actually sort that out, you don't know where to target your interventions well, even at the level of the practice. So I think we need the data, and we need an infrastructure to share that data.
Thank you. If I can may follow with a very brief question, David, which is, what is your thought? You mentioned that in dealing with Health Quality Ontario, there was a reporting going on by a number of primary care groups, but not all primary care groups. Yeah. Do you think there could be an accountability structure here where basically the information is presented, not necessarily with physicians' names on it, but for this practice, here's where we are. And I to this day, I fail to understand why that is not required.
Yeah, so the reason we can't send out a report right now to all family doctors in the province isn't because we don't have the capacity to do it. We actually have the capacity on Ontario Health. Partly it is we believe, or we've been told historically, it's a privacy issue, that the physicians need to consent to have their report released. We also don't have an email address. So we send these reports actually by email to about 50% of the comprehensive primary care physicians in the province. But Terry, we also send a report in groups that are in teams or in family health organizations. We actually send a group level report. And I agree with you. I don't know why we wouldn't be able to make those group level reports public. It's not a blame and shame, right? It's I don't know if there are other groups in my jurisdiction or in my geography that could benefit from some additional help when it comes to targeting patients, running queries in their EMR to find out who the patients who are not doing well are, to share best practices. But we don't even know who of our colleagues we should reach out to, because we're not sharing that data, and not necessarily at the granular individual physician level, but at the group level.
Terry, if I can just really quickly jump in, I would just like to echo some of what David's just said. He talked a few moments ago about the need for that meso level support, and as well as the data, and those are absolutely essential. And I would argue would only go part of the distance without also a coordinating framework and ownership of addressing this problem, which would in turn enable us to find ways to effectively use the data that we already have, and to support primary care, for example, in responding in a way that's helpful and is feasible. Right now, if we're just expecting overloaded family healthcare practices to somehow find a way to generate reports and do something about them without additional support and guidance, I think that's not a viable solution.
Fair enough.
And we know that, back to, again, the reports that and I see there's a number of questions that I'll probably pull into this answer. We know that our My Practice reports They're not management reports. They're quality improvement reports. They're based on the audit and feedback literature. And without giving people the tools to actually look at their data, understand their data, but then act on their data and have the tools to act on their data, you are right. We can only go so far. Again, to quote Dr. Naylor, it's almost like a CT or an MRI. It's a half technology. I remember him used to say when I was in training, and very much the pace. I always tell patients, I can check my weight every day. I can get as many data points as I want by stepping on the scale, but doesn't mean that I'm going to actually lose weight. And I'm talking about me, not them. So.
Thank you. Karen, your thoughts?
Yeah, I think I was looking at one of the things that was coming up on the questions when we were talking about risk profiling. So I don't know if I could speak to that. The risk profiling that happens in the foot is not the same as the risk profiling that happens in diabetes. So I'm not sure if it highlighted that in my talk. That risk profiling actually occurs around features of the feet. These are very well established international guidelines for the foot. When we've looked at studies on how people evaluate feet, we know that they usually only look at one of the 4 criteria that are necessary for risk profiling. And very infrequently do they report a comprehensive, even in that one category. So we know the risk profiling is actually not being done very well. And no, we cannot use the EMR because the EMR has to reflect all of those criteria with respect to that risk profiling. So I just wanted to highlight that maybe I wasn't clear when I gave the talk, that this is very specific to the lower extremity.
That was very clear. Thank you.
Okay, yeah.
Kathy, your thoughts and reflections here? You're leading the brigade for us.
So, diabetes and its complexities really underscore the critical need for an approach to healthcare that will ultimately lead to collective impact. It's not one size fits all, and every individual has a separate set of challenges. So, I think, again, diabetes really represents the chronic disease, the exemplar of the complexity of what we need to deal with. And I'll just make 2 comments. First of all, this has to be a data-driven solution. There's no question. And we can use the opportunity now to link our data, do the data analytics, and get that information to the right people at the right time. So being able to put that information into a framework where there's direct focusing on those individuals who need the most help through managed care and a collective care integrated approach is really where I think we're going to get the biggest bang for the buck here. And virtual care really enables that. And if we're ready to do it, it can really work. I'll give you an example. During COVID, the Limb Preservation Clinic at the Ottawa Hospital had already set up a very excellent data-driven analytic system for their patients. Prior to COVID, they saw maybe 10% of their patients virtually. During COVID, that went to 90%. Their outcomes have actually improved. Why? They're sharing data. They're with care providers in the home with home care. They're linking directly in real time to specialists like Karen Cross, who happen to be in Ottawa, and they're preserving limbs and they're healing ulcers faster. A great model. So we have models in Ontario of best practice that could be spread and scaled today. And in primary care, again, we have pockets of excellence, utilizing data dashboards, analyzing the patient population, and targeting, reaching out to those patients who need managed care with effective care teams. And so we need to identify those best practices, spread and scale, and understand, importantly, how to engage the patients in the precision care pathways that they need to really optimize outcomes and reduce cost.
And if I could say something, I just want to build on that, because I think you summarized, you always summarize things so eloquently and perfectly. I think one of the things that happened as you're speaking about Ottawa is that they put best practice guidelines at the bedside, right? So like I was talking about with time as tissue, these delays they have in the faxing and figuring out when they're triage and who needs to come. The most information I had pre-COVID, before there was this digital strategy, was a fax that said patient has an ulcer. Okay, well, where is it? What part of the foot? That helps me triage them. If it's in their heel versus their forefoot, I don't have anything when I get the information. What happens then is that in real time, or at least within a short order of time, you have best practice guidelines at the patient's bedside, putting the patient back into the center of their own care, right? And I think, honestly, if you look at what the World Health Organization says about mobile health, they say it finally creates that connection with your healthcare provider. The most important thing in adherence, at least when we look at the delivery of care, is how they feel connected to us. Do they feel that we care about them? And it can be a simple, quick little 5-minute visit. We're making it convenient for you. And then finally, a person with a diabetic foot ulcer shouldn't be walking. They shouldn't walk to your clinic. They don't need a 3-hour drive to come and see me. For the most part, I can do a lot of those things virtually. And so I think it's sort of twofold. One, they're getting the protection they need by keeping their foot up. And the second is they're getting real-time best practice guidelines with evidence-based guidelines. And I think that's why, there are going to be a lot of good things that come out of COVID. And one of them, I think, is that. And I think you summarized it perfectly, but I just wanted to say that.
And one of the things that we're doing, Karen, to that point, is at Ontario Health, we've created and we've actually launched the first 2, third one going live this week, taking our quality standards and putting them in a placemat so that they can actually be inserted directly in the EMR, so that the clinician and the physician and everybody else knows exactly what the care trajectory looks like for that condition. So patients can, and it doesn't matter if it's diabetes or heavy menstrual bleeding or anxiety, patients need to see that it's not everything happens in one visit. It does require multiple visits. And I'm hoping that the silver lining with this pandemic has been just the getting over the inertia to do care virtually. And that is either a telephone call or a secure message with a photo. I have to tell you, it's been amazing to see how many patients have been using our secure messaging portal and sending us photos. I mean, the amount of total cost to the system, like lost time to jobs, paying for parking, all these things. It's unfortunately taken a pandemic to move the inertia in our system to get it happening. So a huge opportunity, but we need the guidance also at the bedside or at the clinic side to clinicians.
Terry, if I may, I just think that the last few comments have highlighted what I would consider a response to one of the questions I see in our feed, which is, how would you really implement Diabetes 360 in Ontario? How would you start? Would you start with one Ontario Health team and then kind of roll it out from there? And what my strong message would be is, we don't need any more pilots, any more study, any more sampling or discussing or thinking about it. Some of the some incredible work has been done and has been proven. What we need are means of enabling programs like Dr. Cross just described, like Dr. Bajaj described, like Kathy described, Dr. Whiteside, about that have been proven, that have shown results, that are evidence-based and can rapidly be rolled out, scaled across the country. I would argue that what's missing is not the knowledge, the proof, but the will and the ownership of it. So all we have to do in Ontario, I mean, it's not easy, but it is simple, is we have to claim ownership of this problem, assign somebody to be responsible for coordinating all of our action and resources and helping to facilitate the scaling of programs that are proven to work. And the data integration to be sure that we're making the right decisions and that these interventions are actually sticking. And we can leverage virtual healthcare, but we just need to.
Thank you, Kim. I think it's a very nice transition into.
If I can add to that, Terry, I agree with everything that has been said, especially David mentioned, the pandemic, how it has transitioned our care, and using more digital technology is a boon for many, many things that can be done right with diabetes. I do fear in some parts that, is it possible that if we go, towards digital technology in a big way, that it may create more inequality of care as well? So we have to keep that in mind. Still, the processes and the methods that we have, we stick to them and actually try to reduce the care gaps rather than create more care gaps as well.
Yeah, and I really appreciate that, Harpreet, because if you look at we did a survey just even at St. Michael's, right, where we deal mainly with homelessness, a lot of low socioeconomic status patients, mental health, that's the mission of our hospital. What we found is that a lot of these patients they didn't have a smartphone, right, because they can't afford it, right, or they don't know how to use it, or maybe English is a second language, right, so everything is in English. And we do have to recognize that these we could create a divide, and getting back to one of the questions that was on the screen was about homelessness. And what are we going to do about treating our homeless population, which definitely 100% has more complications in the lower extremity than if you have a home. And I think it's really important. And I think in those situations, there's going to be an opportunity where you say, we have to bring the digital technology to them. So this is going to require a physical visit in certain situations where it's not going to apply to everybody. And I feel like that's one example. This is where we have to use technology to go to them. So maybe the technology is used to screen all of them versus one of them. Maybe that means we bring care and treatment to them, not asking them to come to the hospital. And I think that's really critical. And we always make sure that we're not creating that huge divide. And that's really important to me. And I think coming from Newfoundland, we see that divide very, very. I felt that divide. Most of my family is very poor from rural Newfoundland. Their access to care was very limited. Yeah, so thank you for saying that. And I think the other thing, if I could say one more thing, sorry, is if you look at the data from SARS and you look what happened in the community, I think the second thing that has to happen is we have to support the community. So 30% of all of the patients were afraid to come to the hospital. In SARS, which only really lasted 3 months, that data looks like 5 years. So 5 years, the community was bearing the burden of these chronic diseases. And I think it's also really important not to put more work on our primary care frontline workers, but to offload them very quickly with easy technology, because I actually think they're doing most of the screening and the work. Compared to someone like myself, it's easy to sit in a hospital and say, okay, yeah, we're gonna do this and that, but I think the real work is being done on the front line. And I just wanted to say that as well.
And Karen, back to your point, I think our COVID response, especially like I can only think of Toronto, but the pop-up clinics, the mobile assessment clinics that have gone into shelters across the province or across the city, to all sorts of other things that have never happened before, in the community. I think we have to capitalize on, what this pandemic has done in galvanizing community agencies and providers to work together. I think there's a huge opportunity. And, I spoke to a friend of mine who unfortunately was in New York City for the 9/11. For 9/11, he was a chaplain. He was in school he was a rabbinical student, but he was a chaplain for the fire department. And, his reflection is that 6 months after 9/11, everybody went back to being a New Yorker in the same way. And I think that we can't do that. I think that our community providers can't go back to the way we did business before. The way that we are reaching out into our most hard-hit communities is the way that we have to provide healthcare moving forward for all things, including diabetes.
You're here.
So maybe just to pick up a couple of questions that are coming up, and some of which were there very early in the discussion, so we get some feedback from our colleagues who are sitting out there listening to us. First one here from Espropa. Are you confident the Ontario Health Teams and diabetes care management will be a top priority, and how will the diabetes data PHI flow seamlessly within the OHTs? So a question here again about, we know we've got regions of high concentration with people with diabetes. How do we actually distribute the effort to make that work? And are we confident that Ontario Health Teams are really going to be dispersed in the fashion that was originally recommended, which is really quite focused? So any thoughts from members of the panel?
So Terry, maybe I can comment. I've been looking at the current Ontario Health Teams and their mandates and their priorities. And my understanding is that there's been quickly an engagement, particularly of primary care in the regions, which again is, I think, a critically important part of integration. But again, the issue is whether or not diabetes emerges as an exemplar of chronic disease management and recognized for its complexity and the ability to tackle the challenges of persons with diabetes. And really, there aren't many statements around focusing on diabetes. So one question I would have, for instance, to David Kaplan, is whether or not Ontario Health will begin to provide some direction to the Ontario Health Teams with regard to prioritization.
So I would say that at the moment, the implementation of Ontario Health Teams still resides with the Ministry of Health. I think what I've seen, Catharine, that's somewhat concerning in the applications is that none of the teams, I'm painting in broad strokes, but from all the applications I've seen, diabetes has not been a focus of any of these OHTs. The focus often has been mental health or palliative care or seniors care, all very, very important. But I'm not sure why diabetes, primary care hasn't identified diabetes as an area where we need to put a clinical focus. But it's definitely lacking in some of those, and my own OHT that I'm a member of included.
So I think the question is whether or not diabetes is like cancer. Is diabetes the new cancer? And should it be really managed at a provincial level through public health and making diabetes part of all policy? I think that's where you were going with your discussion. And if we look at the implementation of Diabetes 360, that's really what it's going to need. So putting the onus on Ontario Health Teams or primary care alone, really, I don't think is going to work. I think this needs to be a major priority, just like cancer was. And Terry, you're an expert at that.
That's right.
So you may want to comment as well.
I think it's a challenge. I mean, it's a challenge because we're in the midst of COVID still. It's a complicating factor, to be sure. And I think we need a campaign structure. And I think that's what Kim has been bringing with us. I think we need a campaign structure, not just in Ontario, but we have one of the biggest problems. And the problems need to be directed towards the communities that require the most support. I think it's a matter of kind of making a more visible noise about this with our decision makers, with and through Ontario Health, and through a number of other mechanisms that might be in place to try to raise the bar here. I don't think we yet have a formulation that explains how do we kind of propose a density of support that's proportionate to the distribution of diabetes in our communities. And until we've got some kind of mechanism that's directed in this fashion, as opposed to looking for volunteers, I think we're going to have a challenge. And of course, everything involves money, and money is not a heavy commodity at this moment in time. And you know, people within Ontario Health are working very hard to be extremely cost effective, and I think that's great. But I think we also need to go back and size the dose of engagement with the scale of the disease in the population.
Terry, I think that's such an important point, and it's one of the reasons that we believe Diabetes 360 is such a viable approach, because not only will it help reduce the health burden, but it will actually help to reduce the health costs of treating people with diabetes. And so I think, you know, this is maybe not saying it exactly the right way, but you can pay now or you can pay later. And if we spent the $120,000 that it will cost us to rehabilitate one of Dr. Cross's patients now to help prevent them from ever developing the complication in the first place, we would have that would pay even greater dividends, right? In the sense that that person would live more healthfully, would be able to work longer, would be a more contributing member of society economically. Like there are so many benefits. And one of the key things, you know, Dr. Bajaj and Dr. Whiteside were key members of the team that developed Diabetes 360. And one of the core principles that all of our working groups tried to adhere to was the idea that we wouldn't be going and asking for more and more and more health dollars to implement the programs that we were recommending. We were finding evidence-based solutions that can be implemented in a very cost-effective manner, and that can be basically just a redistribution of existing healthcare resources for the benefit of the system.
And if you look at the ACO model in the States, where they redistributed, you know, in Rhode Island, for instance, 1% of acute care budgets into the community, the impact has been enormous. And, you know, the problem is the in-between, where you're cutting back on hopefully the lead time to prevent one of those ulcers is a number of years. And so there is this period of time where the costs are problematic, but in the long term, they haven't shown to be in some of the high performing ACOs. I think the other thing is that we, in general, have a maldistribution of community team-based resources in the province. We have some areas of the province where 60% of citizens have access to team-based primary care, and other areas of the province where it's under 18 or 15%. And so again, you know, what's the dose that's needed to bolster, especially the patients who are at highest risk for whatever chronic disease, but specifically diabetes. I know I've published on this over a decade ago, looking at patients who've been part of an integrated healthcare team for their diabetes management as opposed to a referral-based team, and the results are pretty remarkable when you have an integrated team that's sitting in primary care. The cost of doing so at a population level, you know, back of the napkin is $50 per patient per year to get everybody access to a team, and then hopefully they only need the team when they need that right dose of intervention. But it's not any more expensive than, you know, full day kindergarten. The question is why aren't we doing it?
So I'm going to read out here, there's a reluctance among policymakers to focus on one of many chronic diseases. And this came out earlier and Kim referenced it. And we've had a bunch of discussion on this topic with the cancer program that Kathy is, the organization that Kathy has launched for Diabetes Action Canada. So, I mean, what kind of campaign would be required to single out diabetes as its particular area of requirement within our jurisdiction? Again, recognizing that there are geographies that have to be attended to and it isn't a bunch of volunteers that will be coming to them. So any thoughts, any creative thoughts about what are the best ways to ensure that the highest risk populations get the engagement they need early on, and there's a kind of a way of organizing that that is sure to be effective.
So Terry, maybe I can start. We've learned in Diabetes Action Canada the critical importance of patient engagement and very meaningful participation in designing research programs, pragmatic research programs that really address the key concerns of patients. And I think the opportunity for citizen engagement in a campaign is critical. And we saw this with cancer. We saw it with mental health. I think we need it for diabetes. But I think also we really need policy decision makers and health system leaders to be engaged in the co-design of some of the solutions that David has talked about, for instance, that are system solutions. And we need to look beyond Canada. Denmark reduced amputation rate by over 80% in about 8 years by creating a hub and spoke method of community-based triage for persons at high risk for amputation. It can be done, and it could be done in our current system. And it's the same for treating or screening for diabetic retinopathy to prevent blindness. Diabetes is still the #1 cause of blindness in working age Canadians. In the UK, they did the same thing. They regionalized screening at a population level. They registered people with diabetes and tracked them. And they have now eliminated diabetes as the most common cause of blindness in about 8 years. So we really need to look across the globe at some best practices and understand that in the end, it's going to improve quality and reduce cost.
Kathy's absolutely right. And I think that really the issue of disease specific versus chronic disease is frankly a bit of a paper tiger. And I think it's something that just requires a bit of careful assessment of the data, which proves that any measure you would take to reduce the likelihood of somebody developing diabetes or its complications would also benefit every other chronic disease or reduce the risk of developing it. We need to look at the fact that all of the patient organizations representing the other major chronic diseases stand behind this strategy because they recognize it will benefit their constituents as well, and just have the political courage to say, we're going to implement this model first, and we're going to build these out for hypertension and for CVD because we all deserve it.
Thank you.
If I can add to that and say one of the things that we worked on very diligently in Diabetes 360 framework is around the concept of wellness rather than just talking about diabetes or diabetes prevention or management. And that encompasses what Kim and Kathy just said, that building wellness among the population will prevent or treat or manage or prevent complications for diabetes, but also reduce the burden of other diseases that coexist as well.
Terrific. Kim, do you have any final thoughts, or Karen? I know
Yes,
one of
sorry.
you will leave shortly.
I'm actually about to go to a meeting about our OHT and our risk stratification for the feet. So that's literally, it was a good segue for me to pop off this call. What I also said in a private message to Terrence was, in the process of 40 minutes, you might see me looking down, I had 4 consults for very urgent feet. So in 40 minutes, just on this conversation, this is my day all day long, looking at pictures and trying to triage them. So I think these are great ideas. And I love the idea of that hub spoke model. I guess I'm sort of physically acting like that right now. So if we could formalize that and have some more of the hubs and a few more spokes together, that would be great. I wanted to thank everybody for the opportunity, and thanks for listening. Don't forget, save the 4 social media. We're going to prevent, 4 limb amputations. And thanks again for your interest. So I'm going to sign off now.
Thanks so much, Karen, for joining us. So we're almost out of time here, or we could stretch a little for a few minutes longer if we need to. I think we still have a strong audience here. So what about maybe to Kathy, the question of having like the 360 coverage, being able to capture all of this data in the repository. Is there an impediment to doing that? Now we have PHRN, we've got a strong start with the repository. I'm not sure it's complete, but it may be possible to make it complete and be able to essentially manage surveillance in this fashion. What do you think?
Yeah, so that's a great question, Terry. And we've set up the repository to accept all forms of data, including image data, full EMR record data. And so it's quite versatile. And we're beginning to work with folks who do machine learning, modeling, and so on, and got a number of projects underway. So it is a fairly versatile data system. And we're very pleased that we have an agreement now with ICES in Ontario to link that data. We also work very closely with community health centers. So we're acquiring all the data ultimately from persons with diabetes in the CHCs. So I think it is a really important first step. And we're very much looking forward to collaborating with both investigators as well as health system leaders and policy decision makers about how to utilize these data.
Yeah, it just seems, that this is a logical way of having some form of population surveillance for diabetes. Maybe it's bigger than people might be.
Yeah, so the big impediment is really being able to do the analytics and re-identify individuals. So this is like the holy grail for the utilization of all personal health data. And we recently have been working with ICES, and we have a project, for instance, for screening people with retinopathy in the province. And we're well underway, I think, to developing a model to be able to work directly with health practitioners to identify those individuals who are unscreened, for instance, for diabetic retinopathy. So this would be in addition to the type of data provided to family doctors that David Kaplan has mentioned.
Yeah, because Kathy makes a great point that we need to provide practice groups with where they need to focus, but they also, once they find out that there is a signal there in their data, they need to be able to re-identify who the patients are and actually action right out of the patient record, send them an email, make a phone call, a text message, whatever it is, for it to be effective. We need to make it easy. It's the balance between practice level reporting and individual patient interaction.
Terrific. Well, it's about 5 minutes to noon. Are there other questions, points people would like to advance here? One question is related to, I guess, sitting in the questions here is the challenges of rural and remote areas. And again, I'm not sure there's a simple solution there, but we've got people in the far north who can only travel by plane. And in some of the lower kind of density communities in the northern part of our province. Any thoughts there on how to kind of have active surveillance of what's going on?
One of the Diabetes 360 recommendations is around really leveraging virtual and telehealth technologies to support people who live in rural or remote communities in receiving care where they are. And we've talked about that a bit today. I'm so grateful for this sort of silver lining of the COVID cloud of the quantum leap forward we've made in terms of being able to offer virtual care. Access to broadband remains a key gap. And when you also factor in that many of the folks living in those rural or remote northern communities in particular are also First Nations, there are other complex factors relating to governance, relating to addressing the long-lasting implications of colonialism that also have to be factored in. And so we need to find the balance, sort of like David was just describing, between having a nationwide framework and commitment towards addressing the problem that also facilitates a community-based support approach, rather, so that we can enable and empower communities to implement measures that really help them address their key issues. And so I think if we can, provide technologies and tools that allow people to be screened for foot problems in their home community so that they don't have to travel out of their community and away from their support network to receive care any more than is absolutely essential. Combine that with measures to get upstream and prevent so many people from even getting to that point, we'd be a lot of the way there.
Here, I'd like to also add that enabling the communities to become more self-sufficient in terms of training, education, and having local caregivers on the ground in those communities, serving the communities in their own languages and with their own cultural sensitivity is critical. And again, I go back to the Stop Smoking program I didn't mention, but that program, a major part of that program is training counselors and health professionals to do the type of work that is local. And so I think, again, for chronic disease management, diabetes, its complications, that's a really key part of the solution.
Excellent. So Matt, I think we're getting close to the finish line here. We've had a very wide-ranging discussion, plenty of spectacular inputs here. We will take this back to our locations, our respective locations, to try to see how we could constructively conspire to sharpen the focus on diabetes and make sure it stands out there. It's not simply a chronic disease. It is a very unique condition that needs its own pathway and its own attendance. So thanks to all of the members of the panel and to all of the folks who attended today. I hope it was useful, and back to Matt for final words.
Thank you. Thank you, everyone. It was a pleasure to work with all of you. There are a number of questions that we may not have been able to address. Your questions are very important. They help our administrators and our leaders and to understand the landscape of those who are in the system and delivering care. I will read the questions with all the speakers and see if there's an opportunity to address some of them, maybe through written response or social media, whatever that may be. Everyone here this morning, including you, the attendees, are working to further the betterment of healthcare and health in Canada. And for those of us who are at risk or have diabetes, please do keep the conversation going. To emphasize Kim's point earlier, the time for evaluations and studies past. Now is the time to make it happen. So let's get together and make it happen. And that's really, I think we're ready to call it a day. And I appreciate everybody for coming out this morning. A fantastic event. We will do our best to get some videos up as well as make slides available for those that are available for us to share. Take care, everybody. Have a wonderful morning and the rest of your day. Have a great day.
Thank you.
Thank you.